Um, for adult males, they have a higher percentage body water because in females, they have higher adipose tissue, and oil and water don't mix, which is easy to remember. Obese people having higher adipose content, having higher fat, having higher oil, have less water. So their total body water is adjusted downward by 10 to 20%. Malnourished people have their body weight, total body weight water adjusted upward by 10% because they have less fat and more muscles. Okay, so in average 70-kilogram male, 60% of the body weight of that male is made up of water. So that's 70 times 60, that's 70 times 0.6, that's 42 liters of water. On average, what's the percentage body weight accounted for by blood? That's 7%. 70 kilograms times 7%, that's 0.07. You have 5 liters, okay, 5 lits. Easy to remember, blood has 5 liters. Average human male has 5 liters. Okay. Now we have this diagram right here taken from Schwartz, showcasing the different body compartments of water. A good mnemonic I have for this is TIE 60-40-20. TIE is total body water. Again, in adult male, it's 60%. Now the total body water is divided into intracellular and extracellular. Now, most of which are found inside your cell to maintain your homeostasis. So 40% of your total body water is actually inside your cells. 20% is outside the cell. Now, outside the cell, it can either be found in tissues, your interstitial fluid, which makes up 15%, or inside your plasma, inside your blood vessels. So that's 5%. The next high-yield question, what's the most common fluid disorder in the surgical patient? It's extracellular volume deficit. The reason for this is that cells would always try to maintain homeostasis. So the water content inside the cells is usually constant. It tries to prevent any changes. So the first to adapt is actually outside the cell. So that's extracellular volume deficit. Especially in newborns, this is very evident by sunken eyeballs, decreased skin turgor. However, in older adults, they usually present neurologic signs, GI signs such as confusion, abdominal pain, abdominal discomfort, among others. What's the most common cause of volume deficit in surgical patients? The most common cause of volume deficit in surgical patients is the loss of GI fluids, either by NGT suctioning, vomiting, diarrhea, or enterocutaneous fistulas. So again, volume deficit in surgical patients is truly loss of GI fluids. Next, high-yield question. How many mEqs of potassium is contained in 1 liter of NSS? So think hard. So this is actually a trick question. You don't have any potassium inside your plain NSS. Again, plain NSS, you only have saline, which is composed of sodium and chloride. So this table showing the two most common crystalloids which we use in surgery, your LR and NSS, is compared against your ECF. As you can see, your LR is the one that highly closely resembles your extracellular fluid. However, we have newer fluids which actually have almost the same content as your extracellular fluid. We have your osmolyte. But the point of this question is just showing you that NSS only actually has sodium and chloride and has 0 potassium. So don't get tricked. Plain NSS, 0 mEqs of potassium. Now, what's the acid-base balance of fluids? Now, lactated ringers, if you think about it, we're going to think lactate is acidotic. But actually, giving plain LR in patients would push them forward into alkalosis. Plain NSS, conversely, pushes you into acidosis. Okay, now LR, alkalosis, why is that? Your lactate there is not just lactate, it's sodium lactate, and it's preferentially pushed into bicarbonate production. Remember, hydrogen ions is acidotic, bicarbonate ions are alkalotic. So if you have more sodium lactate, more sodium bicarbonate, it increases the pH, pushing the patient into alkalosis. This is different from your NSS. Now the NSS, the increased chloride being negative, pushes the bicarbonate. Remember, bicarbonate is usually found outside the cell. If there's increased chloride, it's going to push the bicarbonate inside the cell, thus decreasing the bicarbonate levels in the blood. If you have less bicarbonate in the blood, you have acidosis. So there's a decreased pH. Again, don't get confused. Lactated ringers, alkalosis, NSS, acidosis. Next, what's the fluid that may be used to replace high NG tube output? It's your NSS. Okay, why? What's very helpful is this diagram, is this summarized table right here, taken from Schwartz also, which shows that your NG tube is actually coming from, most of the fluids are coming from the stomach. In the stomach, one of the significant electrolytes found there is your chloride. Okay? Remember, between your plain LR and your plain NSS, which has higher amounts of chloride, your NSS. Next, for diarrhea. So diarrhea, you're gonna think colonic fluid. So in the colon, you have high amounts, significant amounts of potassium. You need to replace it with the only fluid that has potassium, your LR. Or you may include NSS, but you may incorporate potassium collection with it. How about bile fluid? Bile comes from the liver, comes also from the pancreas. If you can see, as highlighted here in the table, your pancreatic fluid and your bile fluid both have increased levels of bicarbonate. So among the two, which has bicarbonate, remember that your lactated dwingers, the lactate there is converted into bicarbonate. Or you can use D5 with bicarbonate. What's the average sodium needed per day? That's 1 mg per kg per day. How about potassium? So easy way to remember, sodium has 2 letters, potassium has 1 letter, sodium is 1, potassium divided by 2, you have 0.5 mg per kg per day. So sodium 1, potassium 0.5. Okay? Next, let's talk about nutrition. What's the most abundant source of energy during short-term fasting? So I know most of you are going to answer glycogen, but this is actually a trick question. It has been asked multiple times in the board exams. It's actually your lipids. This is taken verbatim from Schwartz. Okay. I think the confusion here lies that we know that glycogen is usually used for short-term fasting, but the question is specifically asking for the most abundant source. So if you can see in this diagram right here, glycogen only has 75 grams to spare in an average 70 kilogram meal. However, your fatty acids, your triglycerides can contribute somewhat around 120 grams of fatty acids. And remember, for each gram of that, it's converted to its respective caloric product. If you review your biochemistry or your physiology, we remember that carbs and proteins only give 4 kcal or calories per gram, while your fats give off 9. So again, most abundant, most efficient actually of them all are your fats. So here's a summarized table taken from Schwartz also. Short-term fasting, lipids. Prolonged fasting, especially in the brain, we have your ketone bodies, and after injury, it's lipids. So lipids, fasting, brain, ketone bodies in prolonged fasting. Next, 16-year-old female with anorexia nervosa started on high-caloric parental nutrition, suddenly developed confusion, dyspnea, and irregular heartbeat. What's the most likely diagnosis? So patient has been chronically starved, and you feed them high-caloric nutrition again, you feed them. So that's refeeding syndrome. Now, why is feeding a patient who is starved problematic? This is because of the hormonal response of your body. Her body is starved of calories. If you suddenly push high amounts of calories there, your body is going to get very eager. It's going to increase the production of your insulin. Okay. Insulin does not only push glucose inside the cells, it also pushes the electrolytes around the glucose with it. So the electrolytes involved, we have your potassium, phosphorus, magnesium, and sometimes in other references, we have calcium. But for the board exams, this has been asked before, just remember ppm, potassium, phosphorus, and magnesium, sometimes calcium. Okay. Potassium, phosphorus, magnesium can cause neurologic disturbances, cardiovascular, muscular disturbances. But in the case, chronically starved, refeed them again, it's probably refeeding syndrome. What's the vitamin given prior to feeding? So the vitamin given prior to feeding is your vitamin B1 or your thiamine. Now, the reason for this is that thiamine actually helps in glucose utilization. It actually plays a part in the uptake of glucose and the utilization of glucose. However, another important thing is that in chronically starved patients whom you actually give high caloric nutrition immediately, you can push the patient into Wernicke-Korsakoff syndrome. What's Wernicke-Korsakoff? So Wernicke-Korsakoff, you have confusion, ophthalmoplegia, ataxia, and thiamine deficiency. That's Wernicke, that's coat. The name for that is coat. For Korsakoff, you have retrograde and anterograde amnesia, confabulation, and Korsakoff psychosis. That's coat rack. Okay. Wernicke-Korsakoff, Mnemonic for there is COAT for Wernicke's, Korsakoff, that's RAC. That's COAT, RAC for Wernicke's, Korsakoff. Next, what's the parenteral nutrition that can deliver higher dextrose content? So you only have actually two types of parenteral nutrition. Parenteral means not enteral or beside enteral. So we're thinking of either peripheral or central. When we say peripheral, we make use of peripheral lines. If central, we make use of central lines. So higher dextrose content, of course, you utilize larger veins. So the differences, so for central, you have higher dextrose content. For central, you can give higher osmolarity feeds. Again, the access for central is large diameter central veins. One good example would be your internal jugular vein. And the duration, you can give it longer. As compared to peripheral, which you can give lesser dextrose, less osmolarity, and less length of time. Next, what's the most common serious complication of TPN use? The most common serious complication of TPN use is sepsis, secondary to contamination of the central venous catheter. This is not only exclusive to TPN use. Every time you use a central venous catheter, you always have to think of possible catheter-related infection, possible sepsis from that. So what's the earliest sign according to Schwartz? The earliest sign is sudden development of glucose intolerance in a patient who previously has been maintained on parenteral alimentation. So what's the criteria for sepsis? So sepsis has actually evolved over time. You have a first criteria for sepsis, the historical one, then is evolved into the sepsis tree later on. But for the purposes of the board exams, we just need to understand the historical or the original descriptions of sepsis. So sepsis is SIRS plus a presumed source of infection. So SIRS actually has 4 variables. For sepsis to qualify, you only need to have 2 out of 4. So for the SIRS criteria, we have 2 or more of the following. We have temperature more than or equal to 38, less than or equal to 36, heart rate more than or equal to 90 beats per minute, RR more than 20 per minute, or PCO2 less than 32. The reason for PCO2 being less is because, remember, if you have tachypnea, if you're breathing more, carbon dioxide is being expelled out more. So you're going to have less PCO2. For WBCs, it's either going to be more than or equal to 12,000, leukocytosis, or you can also have leukopenia less than or equal to 4,000. The reason for that is that in severe infection, remember, the WBCs gets exhausted. So it can either go up or go down in cases of sepsis. One thing to remember is that there is no BP in the SIRS criteria. So a good way to remember that is walang BP si SIR. Okay, walang BP si SIR, no BP in SIRS criteria. So actually, description of your infection, sepsis, SIRS is actually a spectrum, right? So we've already discussed infection, SIRS, and sepsis. Let's discuss severe sepsis and septic shock. Severe sepsis is when you have sepsis plus organ dysfunction. It may either be AKI, renal, it may either be neurologic, it may either be pulmonary. So that's severe sepsis. Septic shock, however, is different from severe sepsis because there is already cardiovascular collapse as presented by hypotension. Septic shock, hypotension. But this hypotension needs to be qualified by the requirement of vasopressor support. So your patient is already on inotropes, then you're probably thinking the patient is undergoing septic shock. Now, this is the old one. Later on, we have the sepsis 3 guidelines, which actually makes use of the SOFA criteria. I think that will be discussed more in depth in your internal medicine lecture. For the purpose of surgery, we just need to know the Q-SOFA score. The Q-SOFA score is actually a predictor, not a criteria really, of patients who will deteriorate and who will have severe sepsis later on. So it's usually a helpful triaging tool. So for Q-SOFA, we have 3: hypotension, altered sensorium, and tachypnea. Hypotension, less than or equal to 100 millimeters mercury. Altered sensorium, less than or equal to GCS 14. And tachypnea, RR more than 22. Sepsis, that's 20 RR. For Q-SOFA, that's 22. A good mnemonic for that is that there's a hat on top of the SOFA. Hat, hypotension, altered sensorium, and tachypnea. Next, what's the first-line vasopressor in sepsis? According to sepsis guidelines, the first-line vasopressor in sepsis is your norepinephrine. Okay, norepinephrine. Other vasopressors that you may use are your epinephrine and your dopamine. Okay, so if you're already using triple inotropes, norepi, epi, dopamine, and if for the board exam purposes, or if you want to be pabibo to your consultants later on or your attendings later on, you suggest, Doc, what if we use steroids? Well, that is actually a valid suggestion because according to sepsis guidelines, if you're already exhausted your 3 inotropes, you can add hydrocortisone because some of these patients have what we call your CIRSE. CIRSE stands for critical illness-related corticosteroid insufficiency. So in patients who are undergoing shock, they usually have adrenal insufficiency, which is incapable of meeting their daily demands. If you add hydrocortisone, sometimes the vasopressors will take into action. Okay? Next, what's the initial resuscitation rate in adults with hypotension? The initial resuscitation rate in adults with hypotension are your crystalloids, 30 cc per kgs. Again, in adults with hypertension, we make use of crystalloids, 30 cc per kgs. But take note, in newer guidelines, in more recent conferences and panels and discussions, the first line actually now is blood rather than crystalloids. However, that is not applicable for every institution, and according to the sepsis guidelines, they make still use of your crystalloids. Just a side note, for pedia, crystalloids for initial resuscitation, that's 20 cc per kgs. For blood, that's 10 cc per kgs in pedia. Again, adults, 30 cc per kgs. Pedia, that's 20 cc per kgs. Blood, pedia blood, that's 10 cc per kgs. Okay. Next, what refers to the presence of organisms on the surface of a wound? The presence of organisms on the surface of a wound is what we call your contamination. Surprisingly, questions sometimes as simple as this come out in the board exam, especially in our time. We even have questions pertaining to halitosis and gingivitis in surgery. So there's questions like this that sometimes will put you off your momentum, but try to keep track of your pacing and try to not overthink some of these questions. So this one is taken from Junqueira. Contamination refers to the presence of organisms on the surface of a wound. This occurs before multiplication. Colonization refers to the presence of multiplying organisms. Contamination, it's just there. Colonization, they're multiplying. But both contamination and colonization do not exert a host response. They're just there. They're not interfering with your immune system. They're not eating off your skin, your organs. They're just there. There comes a point where we call it critical colonization, which is the point at which host defenses are unable to maintain the balance of organisms. After critical colonization, that is where we have your infection. Infection is where we have already a host response. Like again, contamination, colonization, no host response, infection with host response. Next, what's the most common cause of fever on post of day 1? Now, this is very controversial. Atelectasis. Now, my disclaimer for this, for the 5 W's of post of fever, is that some authors, some studies suggest that the original 5 W's of post of fever are actually anecdotal. They don't have much body of evidence to prove them. However, in the board exams, this has been popping out every other year. So I guess even though we can't really trust the 5 W's of post of fever, I think it's very helpful to know for board exam purposes only. So it's the 5 W's. We have wind, water, walk, wound, and wonder drugs. So for wind, we have atelectasis if less than 48 hours. If more than 48 hours, we're thinking of pneumonia. So atelectasis or pneumonia. That's why in patients post-op, you suggest incentive spirometry sometimes. Next is water, UTI, which usually lasts 3 to 5 days. So actually, there's a question, what's the cause of UTI in post-op patients? Is usually the presence of a urinary catheter. You remove it, and usually treat empirically, and it resolves by its after a few days. Walk, DVT, so patient who has been post-op, bedbound, remember the well scoring in IM, usually have higher predisposition to venous thrombosis. This is why we sometimes give enoxaparin, we sometimes give, we use compression stockings in patients who are post-op. For wound, we have SSI, and for wonder drugs, usually medications. So 48 hours, wind, water, 3 days, walk, 5 days, wound, 7 days. So there's a 2-day gap in between. Okay. Wonder drugs, more than 7 days or sometimes, depending on what kind of drug you use. So for UTI, more than 10 raised to the power 4 CFU per ml in symptomatic patients. And for asymptomatic patients, it's 10 raised to the power 5 colony-forming units per ml. This is your urine culture. Next, patient underwent laparoscopic appendectomy. 3 of CT reported appendix contained the fecalith. There was no mention of infection, rupture, or inflammation in the op report. What's the class of wound? So we have 4 classes of wounds. We have clean contaminated, we have contaminated, and we have dirty, right? So 4 classes. This question is asking which class does this case belong? So LAP, AP, no infection, rupture, inflammation. So the 4, what's the answer? The answer is class 2, clean contaminated. So we have a table right here, clean, contaminated, and dirty. Okay. Just to go over this very effectively, I'm going to discuss this table right now. For clean, there is no entry into the genitourinary, GI, or respiratory tract. So you don't enter anything hollow, right? So hernia repair, just open skin, you don't enter anything, you push it back in, it's clean, it's class 1. Breast surgery, just remove the breast, that's class 1. However, if you enter something, the GU, GI respiratory tract, okay, such as cholecystectomy, elective GI surgery, then it becomes clean contaminated. There's another separate subsection for colorectal surgery, which is actually still under class 2, but has higher amounts of infection, right? That's why there's a separate row for colorectal surgery there. For contaminated, that's where there is entry and there is inflammation. So there's introduction of bacteria due to major breaks of sterile technique and inflammation, such as in penetrating abdominal trauma, large tissue injury, or enterotomies. For dirty, there's overt infections. There's pus, there's abscess, there's necrosis, or necrotizing infections. That's dirty, right? So for this patient, AP was done. You enter the viscous. It's not inflamed. It's not purulent. There's no necrosis. There's no abscess. You remove it. That's clean contaminated. It's class 2. Next, patient underwent LAP AP. The operative report states it was an inflamed appendix. What's the class of wound? So again, if there's inflammation already, it's already class 3 contaminated. So again, class 1, that's clean. There's no entry in any hollow viscous. Class 2, there is entry, but still somewhat clean. Class 3, there's inflammation. Class 4, there's pus or there's abscess. Right? For this one, it's only inflamed, right? So inflamed appendix, according to Schwartz, also includes perforated or gangrenous. Why? Because Schwartz considers only periappendiceal abscess or those with generalized peritonitis to be dirty. So for an appendix who has just ruptured or is just gangrenous by itself and you remove it, that's still class 3 contaminated. However, if there's pus or there's abscess, that's where we go into your class 4 or dirty. So LAP AP, there's periappendiceal abscess, this is class 4 or dirty, right? Okay, so again, just to emphasize, class 1, there's no entry, class 2, there's entry, class 3, it's inflamed but non-purulent, class 4, it's purulent or with abscess. So easy to remember, right? Next, patient, post appendectomy a year prior, went to your clinic complaining of abdominal pain. CT scan revealed a small bowel obstructions. You're thinking post-op adhesions, right? The most common. XLAP was performed and adhesion lysis frees up the obstruction. What's the class of wound? So I'll give you a few seconds to think about this, right? So you operated the patient, you adhesionized the patient. Did you enter any bowel? Was there inflammation or purulence? No. So the correct answer for this is still a class 1 or clean, right? There's no entry of anything, it's clean, there's no inflammation, there's no purulence. So at first I was confused also, but yes, the purpose of this is I want you guys to be better than me. So I want you at this point to understand differences between these things, and I want you to understand it in a simple way that you can take into the board exam and not just brute memorize everything. Next, fibroblasts and endothelial cells infiltrate the wound to reestablish tissue continuity. PDGF is the strongest chemotactic factor for these types of cells. What's the phase of wound healing described? So we actually have 4 to 5 phases of wound healing, depending on which reference you use. Even Schwartz has different numbers of wound healing, depending if you place it in the table or it's in the paragraphs. But generally, we have these 4 main groups of phases. So we have hemostasis and inflammation, we have proliferation, we have maturation, remodeling, when you have epithelialization. So first, you have an injury. Of course, it's going to stop bleeding first. Then your inflammation comes into play. We have first your neutrophils, which are the first responders, followed by your macrophages and your lymphocytes, which actually bridge the gap between inflammation and proliferation, right? Next, proliferation. What proliferates? So what proliferates are the scaffolding materials and the cells that make those scaffolding materials in the wound. So we have your fibroblasts and endothelial cells. So the chemotactic factor for them is your platelet-derived growth factor. So when platelets go in, they cause hemostasis, they release this growth factor, signaling the endothelial cells and fibroblasts to go in and start producing collagen. But what collagen are they producing? They're only producing the framework collagen, the scaffolding collagen. This is your type 3 collagen. Because later on, that type 3 collagen is going to get remodeled into your stronger and better collagen fibers. That's your type 1 fibers. Now, the enzyme useful for this in your maturation, your modeling phase are MMPs, or matrix metalloproteinases. After a while, we finally go to the last phase, the epithelialization phase. Epithelial cells will migrate and cover the wound. And sometimes, if there's perfect tissue repair, it's like nothing has happened. So that's epithelialization. Next, a 30-year-old male sustained a large injury over his thigh after a dog bite. The wound was left open for 5 days, then closed with sutures. What's the type of wound healing? So there's 3 types of wound healing: primary, secondary, and tertiary. Okay. So for this question, the answer is tertiary intention. While for primary closure or primary intention, primary means you close it immediately. There's a wound there, it's a clean incision, you close it immediately after. That's primary intention. Secondary intention is when you let the body do it secondarily. You let the body heal in itself. So you leave it open and you let it heal by granulation. You usually do this in patients who have contaminated wounds, right? But if you have severely contaminated wounds, such as those occurring from dog bites or from traumatic injuries or laceration with foreign bodies, you do tertiary healing. What's tertiary healing? Tertiary healing is actually a combination of 1 plus 2. That's 3, right? Combination of primary and secondary. So what is tertiary healing? You let it open, let it heal by itself, you let it granulate, and until such time you can see it's already clean, granulation tissue is already healthy, you try to close it up. So that's tertiary healing or delayed primary closure. Next, what's the first priority in your primary survey? So primary survey, how many components do we have? We have 5. We have your A, B, C, D, and E. Right? Actually, I've added 1 recently, exsanguination, but that's not important for board exam purposes. Okay, so what's the first priority in the primary survey? So that's A, B, C, D, E. The first priority is ensuring a patent airway. A comes first before everything. But again, recently we have exsanguination. But for board exam purposes, airway is first. No, it's not only airway, because ensuring a patent airway is not enough if the cervical spine is unstable. So you need to stabilize your cervical spine by using your collars or using specific positioning techniques to make sure that the neck does not get moved too much, especially in patients with brain trauma. Next, this one has come out of board exams a few times. What's the most common indication for intubation? Most common indication for intubation is an altered sensorium. So we have the old adage, GCS8, intubate, right? GCS8, intubate sounds good. But recently they've added GCS8, wait, then intubate. What is wait? Weight is when you need to assess first, you need to correct first if there's acidosis, if there's hypoglycemia. The patient is actually an alcoholic. Sometimes they get intubated because they think they have brain trauma, right? So GCS weight and intubate is a good way to remember that in severe traumatic injuries, which are GCS 8 or less, we need to intubate these patients immediately. What are the components of the secondary survey? We have the AMPLE. So AMPLE stands for allergies, medications, past medical history, last meal, and events surrounding the injury. Okay? Now, corollary to this is there's a question one time which asked, what's the most common obstructing object? So the most common obstructing object, actually, the reason why you need to intubate patients with alpha sensorium is because usually they have poor reflexes, they have poor response to aspiration, and sometimes the tongue falls back to itself. So it's actually the tongue, the most common cause of obstruction. So you need to intubate these patients to protect their airways. If there's a foreign body, what do? If there's injuries, there's foreign body, there's something lodged inside there, the most emergent that you can do is a cricothyroidotomy. Next, 30-year-old male, slip, hit his head on the gutter. On assessment, the patient opens his eyes to speech, speaks inappropriate words, and localizes pain. Usually, one or two questions in the board exams regarding GCS score, and they usually ask you to solve the GCS score. So if you don't memorize the table, you're gonna get confused. Okay. So for this one, eye-opening speech, that's E3, speaks inappropriately, that's V3, and localizes pain, that's M5. We have a score totaling to GCS 11, E3, V3, M5. So we have the old GCS score here. Old I say because this has been recently updated into your GCS 40. Not because there's 40 variables or there's a perfect score of 40, but the GCS score was revised on their 40th anniversary, right? Okay, this simplifies everything. For eye-opening, the lowest score is 1, the highest score is 4, 2 is to pressure instead of to pain, and 3 is to speech as compared to sound. Why pressure? Because sternal rubs, albeit are very kind of not very welcoming to see. So we actually made use of the trapezius pinch, the supraorbital pressure, and the pinching of the nail bed to simulate pressure in the patient, not pain necessarily. And for 3, to speech. For verbal response, we have non-sounds, words, confused, and oriented. For best motor response, basically still the same. So lowest score you get, that's 3. High score you get, that's 15. Again, for eye-opening, non, pressure, speech, spontaneous. Verbal response, non, sounds, words, sentences but confused, sentences but oriented. So this is easy way to remember your verbal response. For motor response, you have extension, you have non-extension, flexion, withdrawal, localizing, and obeying commands. That's 6 in total, right? Still, in the topic of neurotrauma, we have epidural and subdural hematomas, which are very high yield also in the board exams. So this question actually came out in a recent board exam. What hematoma is identified beneath the inner dural layer? So we have epidural and subdural. As its name suggests, epi is above, sub is below. So beneath the dural layer, you have your subdural hematoma. What's the shape on CT scan of your subdural hematoma? Okay. Please try to follow my gesturing here. Okay. Imagine this is bone. Below bone, you have dura. Below dura, you have brain tissue, right? Dura, above it, you have your epidural. Below it, you have your subdural. Your subdural is below your dura, and below it is your brain tissue. Brain tissue is soft, it's movable. So if there's a hematoma here, the hematoma is just going to spread outward. It's going to look like a crescent shape, right? It's just going to spread outward. For the blood vessel involved in subdural hematomas are the blood vessels that are actually very soft, very friable, very thin, right? Because it's just dura and brain tissue here. Every time the brain moves too much, some of these vessels is going to get ripped out. So these are your very thin, very friable, very fragile bridging veins, okay? How about above the dural layer? We have your epidural hematoma. Epidural, above. What's the shape on CT scan? Remember, this is bone, this is dura, this is brain. Epidural above the dura, but below bone. Remember that the dura is actually very closely adherent to bone. It's stuck on bone. if there's a hematoma there, it's only going to get peeled little by little, okay, forming a somewhat lenticular or lens-shaped form, right? It's just going to get peeled off little by little because it's stuck to bone, right? Now, what's the blood vessel involved? Remember that the blood vessel that can overcome the pressure of of a dura sticking to bone, the blood vessel that can only push the dura downward needs high pressure. So it's actually an artery, and one of the more common arteries is the middle meningeal artery, right? Easy way to remember subdural and epidural. Which of the two, however, does not cross suture lines? This also has come in the board exams. Remember, suture lines are your lines of your cranial bones, right? The dura is stuck on those cranial lines, is stuck on bone. So which hematoma does not cross the suture lines? That's your epidural hematoma. Next, does not cross the midline. That is your subdural hematoma. The reason for that is, just remember, this is the calvarium. You have the illustration there, but I like gesturing so that I can visualize the explanation better, right? You have your skull here, right? You have reflections of dura splitting the calvarium generally into two portions, right? With your corpus callosum here, you have your two hemispheres here, but there's one dural reflection here. Dural reflection we call your falx cerebri, right? So the dural reflection here splits actually your two hemispheres. So if there's hematoma here, and the hematoma is just between the dura and the brain tissue, it's just gonna get trapped in one side. It's not gonna go to the other side. So the one that cannot cross the midline because there's a falx cerebri is your subdural hematoma. Again, suture lines, epidural, it cannot cross because it's stuck on bone. Subdural, it cannot cross because we have a falx cerebri. Okay. Next, what's the sign that qualifies pneumothorax as a tension pneumothorax? A tension pneumothorax is only qualified by the presence of hemodynamic instability or your hypotension. Tension. What is your pneumothorax pushing? It's pushing your mediastinum to one side. If there's hematoma, if there's pneumothorax here, it's going to push the lungs here, it's going to push the mediastinum here. As a result, your vessels are going to get occluded. So you're going to have hypotension from these patients. So what we do needle decompression if emergent. So needle decompression historically has been making use of the second ICS, mid-sternal line, second ICS. However, more recent studies have shown that the fourth to fifth anterior axillary line is the best place to do a needle decompression. Needle, not thoracostomy, needle only. It temporizes and allows you to prepare materials for a formal thoracostomy, right? So you do a tube thoracostomy, a closed tube thoracostomy, a chest tube thoracostomy. You make use of what ICS, this has been popping out also in the board exams, your mid-axillary line, fourth to fifth ICS. So that's the best place, right? Okay. For pneumothorax, actually, it doesn't matter. Wherever you try to put a needle, put a chest tube, it doesn't matter. It's going to resolve. However, for hemothorax, the fourth to fifth ICS provides you with a great vantage point not to hit any structures and also allows you to drain it properly if it's in the more dependent areas. It also allows for possible VATs later on. You can put your ports there, right? Okay, again, needle decompression, previously second ICS, mid-sternal line, right? However, according to Schwartz, more recent studies, anterior axillary line, fourth to fifth, that's for needle decompression. That's best now recently. For CTT, or closed tube thoracostomy, that's mid-axillary line, fourth to fifth ICS. Next, what's flail chest? So flail chest is fractures in 3 or more ribs. That's contiguous ribs in 2 or more locations. So the ribs need to be following each other. So second, third, fourth, right? Those ribs should be contiguous. Then it's in 2 points. 2 points of the rib should be injured. Right? That's flail chest. Now, a flail chest is only problematic if it is a pulmonary contusion underneath. It's the pulmonary contusion which actually kills a patient with a flail chest, right? But if you have a flail, description of flail chest, but without a contusion, sometimes we call that only as a flail segment, not a flail chest. Next, for hemothorax, what's the indication for thoracotomy? In penetrating stabbing injuries, only 1 liter is needed. If it exceeds 1 liter on the initial drain, bring the patient to the OR. For blunt injuries, hammer, motor vehicle accident, you need to have more than 1.5 for you to qualify, bring the patient to the OR for a formal thoracotomy, right? We can also use the third criteria is 200 cc per hour for 3 consecutive hours for a formal thoracotomy. Other indications are as follows: kick, hemothorax, tamponade, herniation, air leak, etc. Right? So you have sample cases right here. Stab wound, right chest, 1,200 ml initial output. So stab wound is penetrating. We require at least 1 liter. So this has exceeded your 1 liter. So you can bring the patient to the OR, right? Next, hit by a pipe, left chest. Hit by a pipe, left chest, 1,400 ml initial output. We say that the criteria is 1.5 liters. This does not actually fulfill the criteria for bringing the patient to a thoracotomy. Bullet injury, right chest, first R600, second R100, third R200. So, does not qualify. Why? Doc, 200 cc per hour. So in 3 hours, that's 600, right, doc? So patient already had 600 the first hour. Do we bring the patient to the OR? Well, the criteria should be 200 cc per hour for 3 consecutive hours. So for the 3 hours that you've been observing the patient, each hour should have at least 200 cc. You don't need to exceed more than 600 in the first hour. If it's less than 200 in the second hour, it's not qualified, right? So for this one, 600, second hour 100, so did not qualify. Third hour 200 cc, so it's not consecutive. It does not follow each other. You don't need to bring the patient to the OR, right? You need to make sure na sunod-sunod, okay? First, second hour, third hour, more than 200. Next, dilated neck veins, muffled heart sounds, and declining arterial pressure. This is what you call your Beck's triad. Beck's triad is somewhat sensitive indicator of a patient who's undergoing pericardial tamponade, right? What's the ml of blood that may cause a tamponade? It's usually less than 100 ml, okay, or 100 ml is needed to tamponade the heart, right? ml of blood that you need to remove to stabilize the tamponade is 15 to 20 ml. So in a patient who you're thinking of tamponade, you don't necessarily need to bring him to the OR to stabilize the patient. You can do pericardiocentesis bedside, subxiphoid approach, just to aspirate even as little as 15 to 20 ml or into Schwartz, so that the patient will stabilize somewhat before bringing the patient to the OR for an open thoracotomy and to examine the mediastinum. Next. 22 male, abdominal gunshot wound, heart rate 120s, R40s, BP 80-60, urine output 15 cc per hour. Class of shock, at least. Okay, so we have different parameters. We just need severe to most severe. For this patient, what's important to identify is that patient is already hypotensive. Okay, it's already hypotensive. And there's decreasing urine output. Remember that urine output needs to be at least 0.5 cc per kgs per hour. So this patient is an adult male. So patient should have at least 30 cc or 35 cc per hour. So for this patient, the patient has decreased urine output and has hypotension. This is already a class 3 shock. Hypotension, DPCO, that's class 3. Okay? Class 1, class 2, again, does not have hypotension, does not have decreased urine output. In percentage, what's the blood loss? Good way to remember this is for those playing tennis. I played tennis before, but I'm really not that good in the game, but I just know how to score in tennis. That's 1, 2, 3, love 0, 1, 2, 3, and the fourth score is the game, right? For 0, that's love 0. For 1, that's 15, right? So for class 1, that's up to 15%. For 2, that's 30. Okay. 2 is 15 to 30%. 3 is 40, that's 30 to 40%, and 4, that's game that's more than 40%. Okay, blood loss in percent, 15 to 30, 30 to 40, then more than 40. How about in ml? Well, a good way that we remember this is we just need to divide the percentage, right? So just think, for class 1, it's 15%. If you divide 15 by 2, you get 7.5. 7.5, 750 ml, right? It's class 1. Class 2, 15 to 30. 15 divided by 2, that's 7.5. 30 divided by 2, that's 15. So what do we get? We get 750 to 1,500. Class 3, 30 to 40. 30 divided by 2, you have 15. 40 divided by 2, you have 20. That's 1,500 to 2,000 liters of blood. And for 40, that's divided by 2, that's 2,000. So again, if you memorize the percentages, begin memorizing the tennis scoring system, you just need to identify which class, which percent, then you divide it by 2, you get the actual blood loss in ml, right? Next, what's the approximate ml of blood loss in femoral fractures? It's 80 to 100, 1000 ml. Well, this is important because in patients who come to the emergency room and who are hypotensive, you need to identify the source of bleeding. Because if there's no other source of bleeding, you need to think of more internal causes, right? So you need to estimate the blood loss. So the patient who has a rib fracture, they usually lose 100 to 200 cc of blood. Tibial fractures is 300 to 500 cc blood. Femoral fractures, you get 800 to 1 liter of blood. And for pelvis, you get 2 liters of blood loss, right? Hey, again, just to recap, at what percentage do we get hypotension? It's class 3. Class 3 is 30 to 40. We need to lose at least 1.5 liters of blood before we get hypotensive, right? Okay. So a solitary fracture of the rib, tibia, femur is not enough to cause hypotension. However, a pelvic fracture will cause hypotension because 2 liters is more than 1.5, and 1.5 liters of blood loss is one of the criteria for a class 3 shock, which is characterized by hypotension, right? Next, what can cause can intracranial hemorrhage cause hypotension? So you don't find any injury in the patient, but you identified in CT scan the patient as an hematoma. Would you think that the hematoma in the brain can cause the hypotension? The answer is no. Why? Because the calvarium is only made up of blood, tissue, which makes up most of it, and CSF, right? But the calvarium can only hold 1.5 kilograms or 1.5 cc. So 1.5 with brain there, with CSF there, no matter how much blood you put in there, it cannot exceed 1.5. And again, 1.5 liters, 2 liters is the criteria for class 3 shock. You need to lose 1.5 liters for hypotension to occur, right? So intracranial hemorrhage, no matter how high, cannot cause hypotension unless patient goes to herniation later on, right? In general, BP for the carotid pulse be palpable. So you have the mnemonic CFR, carotid 60, femoral 70, radial 80. So the farther away we get from the more central, the carotid, femoral to the radial, the farther away we get, and the BP is appreciated, the more we can assume that the patient has adequate BP, right? So for a carotid pulse is palpable, you can see it's at least, the patient has at least 60 BP, femoral at least 70, radial at least 80 millimeters mercury. Next, fracture of the proximal third of the ulna with dislocation of the radial head. So just a short, quick review. We have the Monteggia fracture. This is included in your handouts already. So Monteggia fracture, we have the mnemonic Mugger, M-U-G-R. Monteggia involves the ulna. Galeazzi involves the radius, Mugger. Now for the spelling, Monteggia, M ends with A. A being the first letter of the alphabet, you're thinking proximal, right? Galeazzi, Galeazzi, Z is the end. Z there is more at the end of the alphabet. So you're thinking of more distally. So again, to summarize, Monteggia, Mugger, M-U, Monteggia ulnar, Monteggia, M-A, A being proximal, Monteggia ulna, proximal. Galeazzi, Mugger, Galeazzi, radius, Galeazzi, Z, Galeazzi, distal. So Galeazzi, radius, and distal. Okay? This illustration right here is very helpful. Next, what's the organ most susceptible to blunt trauma and is frequently involved in upper torso penetrating wounds? It is your liver. Why? Because the liver is the largest organ in the body. So if you hit somewhere in the abdomen, you have a high likelihood chance of hitting the liver because it takes up much space in your abdomen, right? What's initial evaluations for patients with blunt abdominal trauma? Before, they were using DPL or diagnostic peritoneal lavage. However, it has been since supplanted, been replaced by a more accessible, more affordable, and easier to interpret and less invasive fast or focused assessment sonography for trauma, right? So we actually have 4 areas of the abdomen to identify or to evaluate in FAST. We have the hepatorenal recess on the right, the peristaltic view in the left. Down, we have your suprapubic window, the Douglas pouch, and up, we have the subxiphoid pericardial window. Okay, we have the EFAST. Later on, the EFAST is extended FAST, which has the 4, again, liver, spleen, dependent portion, pelvic area, subxiphoid, which now includes the EFAST, includes the hemithoraces to identify if there's if there's a hemothorax or a pneumoperitoneum or other injuries to identify the thoraces. Next, post-op after X-lab for a gunshot wound, patient was having decreased urine output, increased pulmonary inspiratory pressures, increased cardiac preload, and decreased cardiac output. What's the most likely diagnosis? So these set of parameters, a decreasing urine output, increasing inspiratory pressure, a decreasing cardiac preload, and decreasing cardiac output, are characteristic of what we call abdominal compartment syndrome. So what's the abdominal compartment syndrome? Abdominal compartment syndrome is when the abdomen is when the visceral organs in the abdomen is pushing against the other organs surrounding them, causing symptoms of cardiovascular collapse, right? For example, the bowels are edematous. They're gonna get bigger and bigger. They're gonna expand. As a result, some of those the pressure inside the abdomen is gonna push against your ureters. If they're pushing on the ureters, they're pushing on the renal vasculature. As a result, you're gonna have decreased urine output. Next, if the bowels get larger, it's gonna push up your diaphragm. As a result, if the diaphragm is pushed up enough, the inspiratory effort of the patient will not be enough. Next, if it's gonna push into the great vessels at the back, especially your vena cava, you're gonna get decreased cardiac preload. Blood is not gonna go back to the heart immediately because the bowels there, the pressure there is pressing up against the IVC, right? And decreasing cardiac output. This was a blood pressure of ACS requiring intervention. That's 35 millimeters mercury. Some references will say abdominal compartment syndrome begins to be evident at 20 millimeters mercury. However, this one is a previous board exam question. It just asked, when do we intervene? Even though ACS is diagnosed at somewhere around 20 millimeters mercury, we only need to intervene at 35 millimeters mercury, right? How do we intervene? We open up the abdomen. If the problem is the pressure, we release the pressure. Sometimes we open up the abdomen, we close it with something sterile, then we revisit that if the bowels have decreased in edema later on, we close it back again. So next, burn patients. 20-year-old male suffered second-degree burns at the 20% TBSA. Patient weighs 70 kgs. Calculate for hydration. So what do? We use the Parkland's formula. So for the Parkland's formula, we have a constant factor there. That's 4 multiplied by the total body percentage of burn. So this one already gave you 20%. That's 4 times 20 multiplied by the weight of the patient. So it's 4, which is again constant, 20 burn percent, 70 kilograms. So 4 times 20 times 70, you get 5.6 cc in 24 hours, right? How do you give it? You need to divide it into 8 and 16 hours. You divide it into 2, you give the first half in 8 hours, you give the second half in 16 hours, right? So first 8 hours, 2,000, you need to half your 5.6. So 5,600 divided by 2, that's 2,800. you divide it into 8 hours. That's 350 cc per hour for 8 hours. For the second half, the second 2,800, you need to divide it by 16 hours. You need to give it by 175 cc per hour for the next 16 hours. Okay? Now, there was a previous confusion because Schwartz has since updated their definition for a Parkland formula to the ABA formula, right? And also some references would say that the modified Parkland is different already. Again, Parkland is 4 times TBSA times weight. They say that the newer modified Parkland makes use of 2, right? But actually, in Schwartz, it specifies that the name of that formula using 2 is the ABA formula, right? The ABA formula. So personally for me, if I were asked the question, solve using Parkland's formula, I'm not gonna make use of the modified Parklands unless the question specifies modified Parklands. I'm not gonna make use of 2 because in Schwartz, that modified Parklands is named as ABA formula. I'm still gonna make use of 4. Again, even though 2 is more recent, 2 times TBSA times weight, I still believe in going word by word for the question, right? Because sometimes the examiners, they just try to confuse you. But you need to stick on what's on the question, because if it's in the question, you're not gonna get faulted for that, even if you get a mistake later on, right? Because it's in the question. So if the question is asking only for Parklands, you don't answer modified Parklands, you don't answer the ABA, still go by 4, right? You don't answer 2. Even though 2 is more recent and is more recently accepted, right? Resuscitation as above prevents the conversion of this zone to an even deeper wound. So we have 3 zones. We have coagulation, we have stasis, and we have hyperemia. Coagulation needs excision and grafting. Stasis is just around the coagulation, and hyperemia is the vasodilation surrounding it. So for coagulation, can't do anything about it, you just need to excise it. For hyperemia, it's just inflammation. But the one that you need to save is the zone of stasis. That's where your hydration, your resuscitation, your monitoring of the patient comes in, and wound care also comes in. So, for purposes of the board exam, they don't usually ask you to solve, but when they do, they give you specific parts of the body. For the burn percentages, they give you specific parts of the body, and you need to surmise it from those parameters in the question, right? So a good way I remember this is by this 9-man here. So what I do is I put 9 for the head. So 9 for the whole head, that's 4.5 in the front, 4.5 in the back. 9 for the whole 2 arms, so 4.5 back, 4.5 front, 4.5 back, 4.5 front, 4.5 back. Now, 4 9s for the body, because that's 2 9s in the front, 2 9s in the back. For the legs, that's 9 only for the thighs and 9 for the legs. For the thighs, 4.5 in the front, 4.5 in the back. For the legs, we have 4.5 in the back, 4.5 in the front, and 4.5 in the back. And you have 1 for the genital area, right? So you can try to draw this, and this has helped me. I don't know if you can memorize the whole image, but this has helped me a few times in burn solving. Right? Next, 8-year-old male subcutaneous swelling midline near the hyoid complains of recurrent infections of this mass after an upper respiratory tract infection. What's the procedure of choice? If it's a child with a midline mass, you're thinking more commonly of a thyroglossal duct cyst. And the surgery for a thyroglossal duct cyst is a cystostomia procedure. So what's a thyroglossal duct cyst? Your thyroid moves from the base of the tongue down to its final position at its location in the thyroid cartilage, right? Okay. If it moves down there, it creates a plaque, and the plaque may become persistently patent even after it has reached its final endpoint. And that plaque may become infected later on. Right? So this is your thyroglossal duct cyst. What we do the cystostomia procedure. We remove the cyst, we remove the tract, and we remove the central portion of the hyoid bone, because usually the tract is adherent there. So this is different from a branchial cleft cyst because, again, branchial cleft cysts are more lateral. Thyroglossal duct cyst, the question will usually specify midline, moves with deglutition. Okay? Or if you're thinking of a lateral mass, that's a branchial cleft cyst. So we generally have 3 types: first, second, third branchial cleft cyst. The first one travels from the preauricular area to the middle ear. The second one both travels in the SCM. The second one goes to the tonsillar fossa. The third one goes to the piriform sinus, right? So 3 bronchial cleft cysts, lateral, third duct cyst, more midline. Okay? Next, what's the most common salivary gland tumor? The most common salivary gland tumor is your pleomorphic adenoma or benign mixed tumors. So you have the rule of 80s for salivary gland tumors. 80% are found in the parotid gland, 80% are benign, and 80% are made up of your pleomorphic adenoma. The second most common is actually your Warthin's tumor. Both your pleomorphic adenoma and your Warthin's tumor are actually more benign causes of salivary gland tumors. If we're talking about malignant causes, the most common of which is your mucoepidermoid carcinoma. A mucoepidermoid carcinoma. You have the 25, 50, 75 rule. So 25% of malignant tumors are found in the parotid gland, 50 are found in the submandibular gland, and 75% of those tumors found in the sublingual gland are malignant. So here's the table. I think this is in your handout also. Most common benign, pleomorphic adenoma. Second most common benign, that's Warthin's tumor. Most common malignant, that's mucoepidermoid carcinoma. Second most common malignant, we need to differentiate if it's adult or children. For adults, it's your adenoid cystic carcinoma. For children, it's your acinic cell carcinoma. Again, benign, first, pleomorphic, second, Warthin's. Malignant, first, mucoepidermoid, second, different if adult or child. Adult, you have your adenoid cystic carcinoma. For child, you have your acinic cell carcinoma. Next, 50, status post-parotidectomy for pleomorphic adenoma, noted swelling at sweating at the right side for operation during feeding. What's the most likely diagnosis? So this is your, when the patient eats, they cry, sometimes it's called as crocodile tears. This is your Frey syndrome. So Frey syndrome is an aberrant reinnervation of postganglionic neurons, right? So you most likely have injured a certain nerve here, and after it has been injured, it reconnects sympathetically to the sweating cells there. Right? So every time you eat, every time that nerve becomes stimulated, it also sends feedback to the sweat, causing you to sweat. After the sweat glands, causing you to sweat every time you eat. That's your Frey syndrome. And the nerve involved in your Frey syndrome is the auriculotemporal nerve, which is actually a branch of the V3 of your trigeminal nerve. Right? Frey syndrome, auriculotemporal nerve. However, the question, most commonly injured nerve in parotidectomy, so that you just don't get confused, okay? Frey syndrome is classic. It has been asked in the board exams, but I think the board of examiners will try to confuse you by asking the most commonly injured nerve. Frey syndrome, auriculotemporal nerve, but it's not the most common. If parotidectomy, the most common nerve involved is your marginal mandibular branch of the facial nerve. Again, it's the marginal mandibular branch of the facial nerve. It's the most commonly injured nerve in parotidectomy. Next, 40-year-old female underwent FNAB for a solitary thyroid nodule. Biopsy revealed Samoma bodies and orphan Annie nuclei. What's the diagnosis? Okay, Samoma bodies and orphan Annie nuclei are characteristic of the most common type of thyroid neoplasm or papillary carcinoma. Again, it's the most common type of thyroid malignancy. So we're orphan Annie nuclei here with nuclear grooving, empty spaces between those, looking like your cartoon orphan Annie, right? Good mnemonic also for the Samoma bodies is you have your Samoma, PSM, P, papillary carcinoma of the thyroid or papillary carcinoma of the kidneys, S, serous adenoma, M, meningioma, right? Samoma, PSM. What's the most important prognostic factor for patients with thyroid CA? It's actually the age. Before it is 45. More recently, it has been 55. Why? Interestingly, if you have metastasis, but you're less than 55 years old, you only get stage 2. But if you have metastasis and you're more than 55 years old, you're going to get stage 4. Right? So that's a peculiar thing about your thyroid malignancies. Next, Type of neck dissection that removes level 1 to 5 lymphatics but preserves the spinal accessory nerve, the IJV, and the sternocleidomastoid muscle. We have your MRND, modified radical neck dissection. You have 3 types of your MRND. Depending on what structure you preserve, you have type 1, 2, and 3. If you preserve the S, the first one, the spinal accessory nerve, that's type 1. If we preserve the S and the I, that's spinal accessory nerve plus internal jugular vein, that's 2. If you preserve the spinal accessory nerve, the IJ, and the M, sternocleidomastoid muscle, you get type 3. So the name for that again is SIM. 1, S, spinal accessory nerve. 2, SI, spinal accessory nerve, internal jugular vein. 3, spinal accessory nerve, internal jugular vein, and sternocleidomastoid muscle. Okay? If you have different types of dissection, I just included a diagram here for you to understand, for you to reminder, for you to identify, to familiarize yourself with the diagrams, right? Because sometimes the board examiners will try to differentiate posterolateral versus lateral versus anterolateral neck dissection. Next, patient with increased PTH, increased calcium, but decreased phosphate. What type of hyperparathyroidism? We have primary hyperparathyroidism. I know this will be discussed more in depth, I think, in ureteral medicine in your patho lectures. However, this has popped out in the surgery board exam. So for primary, increased PTH causes increased calcium. So examples would include your adenoma, hyperplasia, and your carcinoma. Most common of which is your adenoma. Right? For secondary, the increase in PTH is only secondary to a decrease in calcium. Remember that PTH is increased if calcium is decreased because PTH will try to push calcium up, right? It's going to feed back. So the secondary hyperparathyroidism is due to a decreased calcium, such as in calcium-losing diseases such as your chronic renal failure and vitamin D deficiency. However, if that chronic renal failure, patients who are post-transplant, patients who have renal problems, chronically ongoing, which predisposes the patient to a tertiary type of hyperparathyroidism in which everything is increased. Okay? What's the classic pentad of symptoms? This also come out of the board exams. You have stones, bones, groans, moans, and overtones. Kidney stones, painful bones, abdominal groans, psychic moans, and fatigue overtones. Right? How to localize? We need to use a sesame B scan or 99 technetium scan. If it's only one gland, then that's most likely an adenoma. So what do? You just remove that gland. If there's more than one gland, this is usually hyperplasia. And what you do is you remove 3.5 parathyroidectomy or a total parathyroidectomy, then you autotransplant. What's autotransplant? You remove one, then you plant it where? Sometimes in the SCM, sternocleidomastoid muscle, sometimes in the forearm, right? For carcinoma, you do end block resection, then remove one part of the thyroid lobe. What's the most common location of a missed gland? So this might be confusing. Missed gland means that you missed it. If you missed it, it's probably where you left it. It's a normal anatomic location. However, if the question is asking for the most common location of an ectopic gland, ectopic means it's really not there. The most common location is the thymus, right? Missed gland, normal, ectopic gland, thymus. Next, nodes interpose between the pectoralis major and minor and receive lymph drainage directly from the breast. So between both pectoralis muscle, your interpectoral nodes or Rotter's nodes. Okay, so you actually have 3 levels of nodes in the axilla. You have level 1, 2, and 3. Level 1 is lateral, level 2 is the one between your muscles, and level 3 is your mid-lateral, right? So what muscle serves as the landmark for this one? The muscle that divides the axillary groups or your pectoralis is your pectoralis minor muscle. Okay, next, also for the anatomy of the breast, which quadrant is usually associated with malignancy? Of course, the quadrant with the highest percentage of breast tissue, up to 75%. And this is the lateral, upper lateral quadrant, upper outer. Why? Because you have a tail of Spence extending into the axilla there. It's where most of your breast tissue is found. Thus, it's the site of the most more common quadrant associated with carcinoma. Next, 40-year-old female underwent sonomammogram result BI-RADS 4. What's the next step in management? So for BI-RADS 4, this is actually suspicious for malignancy. What you do is you perform biopsy. So the BI-RADS scoring system is used to identify patients with breast imaging, whether ultrasound or mammogram, and correlate it into the risk of developing a malignancy so that you can form a management plan later on. Just so that it doesn't confuse you, Bethesda is thyroid, BI-RADS is breast. A way to remember this is Bethesda has a letter T, T is thyroid there. Okay? So I remember it because personally I get confused sometimes. Both are letter B, Bethesda, BI-RADS, which is which? BI-RADS is for breast, Bethesda is for thyroid because of the letter T there. Bethesda is actually FNAB result. Your BI-RADS is imaging result, right? So here we have 6 levels, but we actually have 7 categories because you include 0 there. 0, bar 0 is incomplete, so you repeat the imaging. 1 and 2, 1 is normal, 2 is benign. So what do? You do a routine screening on the patient. Okay? 3 is benign, probably benign. 4 is probably malignant. 5 is highly suggestive malignancy. And 6 is biopsy-proven malignancy. Okay? So again, 1 and 2, routine screening. 3, you do short interval follow-up. So instead of annual, you do it abbreviated into 6 months. Okay? For 4, it's probably malignant. You get 4A, 4B, and 4C, low, intermediate, moderate. Basta for all those, you do biopsy. So ideally for the breast or first-line biopsy technique is your corneal biopsy. Or sometimes FNAB might be acceptable, but the FNAB will not guarantee you identifying carcinoma because if it's low yield, also, you won't identify if it's invasive or not. You just know that there's cancer there using the FNAB. Because again, the FNAB has a smaller needle. It only gets the cells. Your core needle gets the architecture because it's larger. It can put more tissue inside your specimen, right? 5, highly suggestive malignancy, appropriate actions. You do biopsy, prepare the patient for surgery. And 6, that's already biopsy proven. So you proceed with your next workup or with your next management. Either chemo or neoadjuvant or you need to do per surgery. Okay, take nodes. Right? I've summarized the number of nodes needed for certain surgical procedures or oncologic resections. For breast cancer, it's 10 to 15. Again, 10 to 15. Take nodes. Minimum number of nodes in gastric cancer, it's 16. And gastric cancer, 16. Colonic cancer, it's 12. Gallbladder cancer, it's 6. Breast cancer, it's 10 to 15. Gastric cancer, it's 16. Colonic cancer, it's 12. Gallbladder cancer, it's 6. Okay? Next, SERM, a selective estrogen receptor modulator, first shown to reduce the incidence of breast cancer in women. So, remember, if we're taking a biopsy sample of a breast patient, we also need to identify its hormonal status. We get the ER, estrogen receptor, progesterone receptor, and the HER2/neu. Okay? The ER/PR there is for you to decide what best treatment to give to the patient. If this patient can be given a certain type of treatment, this treatment is hormonally mediated because these are estrogen and progesterone receptors. So we have the SERM. We use tamoxifen as adjuvant hormonal therapy or as chemoprevention. So tamoxifen targets the estrogen and prevents breast tissue from proliferating. That's your tamoxifen. Side effects, endometrial cancer, thromboembolic events, cataract, and vasomotor disturbances. Molecular subtypes responsive to tamoxifen, we have 2. This is popped out in the board exam. We have luminal A and luminal B. A and B both are ER positive. The difference is that in luminal B, you will have a positive HER2/neu. Luminal A is only positive ER with or without PR. B is ER with or without PR with HER2. HER2 is only HER2 enriched, triple negative, worst prognosis, negative everything. Okay. Again, worst prognosis is a triple negative breast cancer. Next, more effective in reducing the incidence of contralateral breast cancer in postmenopausal women. So, in premenopausal, we give SERMs, we give tamoxifen. In postmenopausal women, we give aromatase inhibitors. A good example would be your anastrozole. Okay, tamoxifen for premenopausal is not actually also suggested to be given to postmenopausal women because tamoxifen increases the chance of cardioembolic events. Okay. Next, melanoma screening. What does D stand for? D stands for diameter. We have asymmetry, border, color, diameter, and involving. The diameter there is more than 6 millimeters. What's the most common subtype of melanoma? Superficial spreading. Okay. So different types: superficial spreading, nodular, lentigomaligna, and acral lentiginous. This is in your handouts. Just want to remind you, most common subtype, we have your superficial spreading. We next should memorize all the Clark levels, but I'll leave that to you on your handouts. Sorry, I'm trying to include everything in the short amount of time that I have. So I'm still pacing myself, but sorry if I get too fast in a bit. Okay. 30-year-old female, developed tender deep nodules at axilla and inframammary fold. What's the most likely diagnosis? So I know sometimes the board examiners have fetishes for different dermatologic conditions, because I think one of the board examiners before was derma. This has popped out in patho, IM, and also in surgery. So this is your hidradenitis suppurativa. So usually you treat this medically at first. If it's persistent, you need to excise the apocrine glands that are chronically inflamed. So multiple tender nodules is hidradenitis suppurativa. Next, abdominal wall hernia found in the junction of the semilunaris and the arcuate line. So in between the semilunaris and the arcuate line, you have your Spigelian hernia. So it's more lateral, as compared to the epigastric and umbilical hernia, which are more midline. What's the hernia of the back? So we have two. We have the superior lumbal triangle hernia, the Greenfeld shaft, and the inferior triangle hernia, the petit. A good way to remember this is Greenfeld, Le shaft, superior. Greenfeld sounds like Gryffindor, and Gryffindor is superior. So Greenfeld, Le shaft, superior triangle. Petit means small, petit means inferior, so inferior triangle, right? Next, type of hernia with strangulation but without obstruction. So if a hernia gets strangulated, you're gonna think, if it's strangulated, no bowel is gonna come out, right? But there's one type of hernia in which even if it's strangulated, some of the bowel contents can still pass through, so it's not obstructed. So this is your Richter's hernia. Richter's hernia, because in Richter's hernia, only one side of the bowel is strangulated. The other side is still open. Bowel contents can still pass through. That's Richter's hernia. Okay, so we have some names, eponyms of hernias here that I'd like to give mnemonics to so that you can easily remember them. For Richter's hernia, Richter, I remember this as recta. Why? Richter hernia, you can have strangulation but it's not obstruction. So recta pa rin yung bowel contents. So recta, Richter's hernia. Next, litter hernia, litter for little, because in little patients, we have your Meckel's diverticulum, right? For pantaloon hernia, parang pantalon, so you have two legs, you have two legs of the trousers, so you have a direct and an indirect hernia. In between is your inguinal inferior epigastric vessel, right? For Madel's hernia, there's two bowels in the sac, Madel's. So we remember this is Madel's, may dalawa, Madel's hernia. And we have the Amian's hernia, which is herniation of the appendix. So Amian, letter A, Amiandix. Okay. Next, what are the borders of the triangle of Hasselbalch? Medially, we have your rectus abdominis muscle. Superolaterally, we have your inferior epigastric vessels. Inferiorlaterally, we have your inguinal ligament, right? So if it's medial to the inferior epigastric vessel, we have your inferior epigastric vessel here. If it's within the Hasselbalch triangle, it is a direct hernia. Direct because this is a triangle, right? You have the inguinal canal right here, right? If it passes the Hasselbalch triangle, it's directly on the inguinal canal immediately. However, if it's outside the Hasselbalch triangle, it needs to pass first to the internal ring. So that's your indirect hernia, because indirect, it's not directly going into the sac. It's gonna pass through the internal ring first, then the canal, right? Or sometimes there's a question in our board exam which asked laparoscopically what marker can be used to identify if it's a direct or indirect hernia. You have the lateral umbilical fold. Okay. Next, for the NIHOS classification, we have 4 types. Type 1, is where you have a normal internal abdominal ring. Type 2 is where the ring is enlarged but does not extend to the scrotum. Type 3 is where you have indirect sliding straddle and pantaloon hernias, and type 4 is your recurrent hernias. Okay. For type 1, ring normal. Type 2, ring enlarged. Type 3 is when the hernia sac and the bowel contents and everything goes in. Okay, that's already type 3. Specifically, it's type 3B because type 3A is a direct hernia, type 3C is a femoral hernia, and type 4 is already recurrent. Again, NIHOS 1, normal ring. NIHOS 2, large ring, but no bowel contents inside. NIHOS 3B, extends inside, goes to the scrotum. That's 3B. 3A is direct. 3C is femoral, and 4 is recurrent. But more recently, we have been using the European Hernia Society classification. The NICE classification is old, but it's still being asked in the board exams. It's very helpful for you to memorize it. Basta normal, enlarged, umaabot sa scrotum, that's 1, 2, and 3B. 3A is direct, 3C is femoral, and 4 is recurrent. Next, congenital hernias naman. Newborn noted visible bowel and viscera covered with a complete sac and is found in the midline. Covered with a sac in the midline, that is your omphalocele. A good way to remember this is O. O looks like a sac. O looks like it's in the middle. Now, you need to differentiate an omphalocele versus gastroschisis, right? For an omphalocele, it's in the midline, it's in the umbilicus. For gastroschisis, it's in the right. Gastroschisis, gastrite. So you remember it. For fascial defect, it's variable. For gastroschisis, usually less than 4. The sac is present in omphalocele and is absent in a gastroschisis. Okay. For omphalocele and gastroschisis, we need to identify which is which because there is a prognosis that is different for each type of defect. So which of the two is more severe or more worse? That is your omphalocele. Why? Because the omphalocele, as seen is stable right here, is actually associated with other anomalies such as your cloacal exstrophy, Beckwith-Wiedemann, and your Candida's pathology. Where gastroschisis, although it might look very bad because you can see bowels are going out, but take note that those bowels outside are already leathery and shortened. They have adapted to the amniotic sac. They have adapted being outside the abdomen. So it's actually very tough. When you put them inside, the patients usually go back to normal. As compared to omphaloceles, which usually have other defects. Most common of which are your cardiac anomalies. Okay. 20-year-old male presents with abdominal mass. Physical exam reveals that the mass only moves laterally. What's the diagnosis? So, 20-year-old male, abdominal mass inside. The mass can go left and right only. This is your Tilao sign, which is identifier of your mesenteric cyst. As compared to a mass that goes in all directions, your omental cyst, omental, all directions, we can easily visualize them by thinking mesentery, remember, is at the back. It holds your bowels to the retroperitoneum. Your omentum is in the front. It's just there. It's just lying around, right? So in the mesentery, if you have a cyst there, remember, it's stuck to the peritoneum. It can only move to one side or one direction. Up, left, right, right? If it's in the front, if it's in the omentum, it can go anywhere it wants. So Tilao sign, mesenteric, omental, all directions. For abdominal wall masses, also, we have an anterior abdominal wall mass that do not cross midline and is still palpable when the muscles are tense. We have the Fothergill sign or the rectus sheath hematoma. So the Fothergill sign, you palpate the mass, you ask the patient to sit up. If the mass is still there, it means that the mass is in the abdominal wall. Right? Most likely in the rectus sheath, most probably from a hematoma. Right? However, if the mass disappears, it means that the muscles has contracted and prevented the mass from being palpable. So it's usually it means that the mass is at the back. So it's a negative Fothergill sign. It's not rectus sheath hematoma. But if it's persistent, if it's there, that's a rectus sheath hematoma and a Fothergill sign, right? Next, patient presents with dysphagia. Esophageal manometry done revealing incomplete relaxation of the LES. Hypertonic with aperistalsis. What's the diagnosis? So this is characteristic of your achalasia. Achalasia is very classic. It's very historical. It's very significant. It sounds very okay. Sounds very nice. However, achalasia is not the most common. I'll show you what's the most common later on. So what's the imaging modalities? We can use of X-rays, we can use of upper GI series, where we identify the bird's beak sign. The bird's beak sign is where you have a beak at the point where the muscles of the esophagus are so tense, it's not allowing any contrast to pass through. So that's your achalasia. What's the treatment? If the problem is the muscles, what do? You relax those muscles by doing incisions. You can do laparoscopically, you can do it open. We have the Heller's myotomy. Heller myotomy. Myotomy, muscle-tomy, splitting, muscle splitting. You just split the muscles to allow it to relax. Now we have different motility disorders, and sometimes they have questions which describe a particular manometric reading, and you need to identify which is which, right? Right. So I'm going to simplify it for you. So we can differentiate them first into high or normal LES pressures. We have achalasia or hypertensive LES. For both of them have high LES pressure. So let's group them together. Next, for normal LES pressure, we have your diffuse esophageal spasm and nutcrackers. LES, by the way, is lower esophageal sphincter, the one just before the stomach, right? If it's high, it's either achalasia or hypertensive LES. Okay. The way I remember this is that in hypertensive LES, the LES is hypertensive, but it's just that. The peristalsis there is normal because it's just hypertensive LES, right? However, if there's peristaltic dysfunction, if there's absence of peristalsis, then that's already achalasia, right? Tense LES, it's either hypertensive LES or achalasia. If it's just a tense LES, it's hypertensive LES. If there's absence of peristalsis, it's also achalasia, right? Next, if the LES pressure is normal, okay, you can either think of DES or nutcracker's esophagus. So what is DES? Diffuse esophageal spasm. So remember, you have your esophagus right here, right? Esophagus right here. If the peristalsis is high amplitude, but it's not coordinated, it's going here, 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 here. It's not going to one direction, and that's diffuse esophageal neoplasm, right? Sometimes identified as a corkscrew esophagus. For the nutcracker's esophagus, it's coordinated. It's going up to down, mimicking a normal peristalsis. But the problem is that it's very, very, very strong. And it's a nutcracker esophagus, right? The most common severe motility disorder, it's your nutcracker's esophagus. Again, achalasia is just classic. It's just historical. It's high yield. However, the most common still is your nutcracker's esophagus. Okay, so easy way to remember your motility disorders of the esophagus. Next, infant presents with excessive drooling, inability to pass an orogastric tube into the stomach. What's the diagnosis? The diagnosis is your tracheoesophageal fistula, right? If you can't pass an OGT, there's probably an atresia there in the esophagus. It's usually associated with a fistula, right? So we have actually 6 types. You have your A, B, C, D, E, F. However, the more important ones are your A and your C. The most common type of TEF is your type C. Your type C is atresia with distal tracheoesophageal fistula, right? The second most common is your type A. Okay, esophageal atresia without tracheoesophageal fistula. Okay, sorry, I'm running out of time, but allow me to extend for a bit. A is just atresia without a fistula. So the esophagus is just problematic there. The trachea is okay. Next, atresia, but on top, there's a connection to the trachea. That's atresia with proximal compared to your type C with atresia, but the distal end is connected to the trachea. Type D is a double fistula. Type E is fistula with atresia, and type F is stenosis. But then, what's the diagnostic sign? You try to insert an OGT, and if it can't pass, yes, Doc, sorry.
Doc, your camera is off.
Ay, sorry. Can you see me now, Doc?
Yes, Doc.
Okay, thank you. So, if the OGT passes into the stomach, okay, if the OGT passes into the stomach, it's not atresia. But if it coils up and you see it on an X-ray, and the patient is drooling with a classic pathognomonic signs, you're thinking of esophageal atresia. However, among the 6 types of TF, there's one that does not present as an inability to pass the OGT. Right? Which of the 6 is not present as inability to pass an OGT? The one that does not have an atresia. That's your type A. TF without atresia. Okay? X-ray, just so that I can emphasize to you, you can see both X-rays have an OGT that does not reach the stomach. So both must have an atresia. However, we need to identify if this is a type A or type C, the two being the most common, C being the most common, and A being the second most common. Type A usually has a gasless stomach. Why? Because there's no fistula. If there's no fistula, the stomach will always be collapsed because there's no air going to the stomach. But if there's a fistula, it's most likely type C. Esophageal atresia with distal tracheoesophageal fistula. Right? Next, what's the most common type of esophageal cancer worldwide? So the most common type of esophageal cancer worldwide is your squamous cell carcinoma. What's the most common type in the middle third of the esophagus? Still your squamous cell carcinoma. A good way to remember this is squamous, second portion, smoker. Squamous, second portion, and smoker. It's in the middle, squamous and smoker, letter S. Okay. For the distal third of the esophagus, we have your adenocarcinoma, and it's actually more common in developed countries, right? But worldwide, still squamous carcinoma. So a good way to remember this is adenocarcinoma and acid. Distally is where your acid reflux goes in, right? So distal third, adenocarcinoma, and your acid. What's the most important etiologic factor in the development of primary adenocarcinoma of the esophagus? So for adenocarcinoma, it has a precursor lesion, which we call as your Barrett esophagus. Okay, this is transition from the normal squamous epithelium to the columnar type. Columnar being more resistant to acid. You only expect to see columnar in the intestines. However, if you see it in the esophagus, it means that the esophagus is trying hard to prevent acid from hurting the esophageal structures, right? So it's transitioning from squamous to columnar. So that's your Barrett's esophagus. Next, we go to the hiatal hernias. The most common type of hiatal hernia, we have your type 1 sliding hernia. Type 1 being the most common type, and it's also the one that is treated medically, or type 1 sliding hernia. So type 1, you have a hernia defect here. It's sliding, it just goes up and down, up and down. The GE junction, the cardia goes up and down. For type 2 rolling, if you have a defect here, you have the esophagus here, one part of the stomach, particularly your fundus, remember the fundus is the cap of the stomach, the head of the stomach, goes at the side. So it's rolling at the side, right? It's for the sliding, which goes up and down, rolling goes in the side. Type 3 is combined 1 and 2, and type 4 is an additional organ. So it's usually colon or other organs, aside from the stomach. Okay? Next, type of ulcer with increased acid output. We have Johnson classifications 1 to 5. The ones associated with increased acid output, as asked in the previous board exam, is your type 2 and 3. So for Johnson's classification, we have 1, 2, 3, 4, and 5. 1 is less, 2 is 2, 3 is pre, 4 is door, 5 is NSAID with 5 letters. So ceremony for it. 1, 1 less. Less, lesser curvature. 2, 2. 2 ulcers, gastric and duodenal. 3 is pre. Pre-pyloric means just before it ends the pylorus, there you have a ulcer there. 4 is door, opening into the stomach. If you have the stomach here, if your GE junction here, the door is right here, right? So if the peptic ulcer is there, that's type 4. And 5, NSAID, because NSAID has 5 letters, okay? So 1 less, 2, 2, pre, 4, door, 5 is NSAID. Types of ulcer with decreased mucosal protection, you have type 1 and type 4, because type 5 is NSAID induced. Most common complication of peptic ulcer disease is your bleeding. The second most common complication is your perforation. Okay. Eventually, you have your obstruction and we have your malignancy, but those are less common complications. The most common is still bleeding. Upright chest radiographs shows pneumoperitoneum in which percent of cases? It's only accurate in 80% of cases. So you can have a patient who has a perforated stomach but will not present with pneumoperitoneum in 20% of cases. 1 patient out of 5. Okay. Next, we go to the liver. Upper border of the triangle of Callot, we have the cystic artery. Structure in the center of the triangle of Callot, we have your Callot's node. Now, the confusion lies in that Schwartz actually got confused himself, right? Because in Schwartz, he states that the hepatocystic triangle is actually the same as the triangle of Callot. But if we base it off anatomy books, they actually specify that the triangle of Callot is different from the hepatocystic triangle. As shown in this illustration right here, get out my pen. The yellow one is the Callot triangle. The Callot triangle is included in the larger hepatocystic triangle, right? In the center of the triangle of Callot, you have the callose node. In the center of your hepatocystic triangle, you have the cystic artery. Okay, the upper border of the triangle of Callot, we have your cystic artery right here. Let me erase so that you can see the diagrams again, right? Okay. So you can see that the upper border of the triangle of Callot is still your cystic artery. However, for the hepatocystic triangle, the upper border is the liver. The rest of the borders are the same for both Callot and hepatocystic triangle. The medial border is the common hepatic duct. The lateral border is the cystic duct. Okay, the difference is the superior border. Callot, cystic artery, hepatocystic, hepato gives you idea that it reaches up to the liver. Okay. In Callot triangle, you're trying to find the Callot node. In the hepatocystic triangle, trying to find the cystic artery, right? Okay. Gunshot wound to the liver, Pringle maneuver applied, liver bleeding unchanged. What's the injury? So if there's a gunshot wound to the liver, we're going to think an injury to the portal veins, hepatic veins, and the hepatic arteries. So we're going to stop the source of bleeding by stopping the vessels that feed the liver. So you can clamp the hepatoduodenal ligament and stop the bleeding of the liver. However, if the bleeding persists, what does it say? It means that the bleeding comes at the back of the liver, retrohepatically by the inferior vena cava and the retrohepatic veins, right? Okay, so Pringle maneuver, if it stops bleeding, okay. If it does not stop bleeding, this is a board exam question, the bleeding usually comes from the back, the inferior vena cava, or the retrohepatic veins. Okay. Next, patient underwent cholecystectomy for gallstones. Biopsy revealed GBCA, gallbladder carcinoma. Histopath reveals a tumor to invade lamina propria. The next surgical plan, so what do? You do a cholecystectomy. It turns out malignancy, but it's only up until the lamina propria. What do? Do you do hepatectomy? Do you do oncologic resection? You do nothing. Because for tumors to the gallbladder that only extends up to the lamina propria, I don't need to do anything. Cholecystectomy is enough. This is T1A lamina propria. No matter how busy this table gets, I just want you to understand lamina propria, T1A, gallbladder cancer, cholecystectomy alone enough. You just need to reassure the patient, and you can do monitoring or whatnot, but you don't need to do anything else. But for type 1B onward, you need to do more oncologic resection. You need to remove part of the liver. You need to remove some ligaments. Basta, just remember T1A, lamina propria, GBCA, cholecystectomy, just okay. Bile duct carcinoma. So GBCA is different from bile duct carcinoma. Bile duct carcinoma is otherwise known as your cholangiocarcinoma. And we have a special type of cholangiocarcinoma. Actually, it's a common type found in the hilum between where your common hepatic duct bifurcates to the right and the left hepatic. You have your Klatskin's tumor. So Klatskin's tumor is again cholangiocarcinoma of the bifurcation or the hilum of the biliary ducts. So how do we how do we classify them? By the Bismuth correlate classification, and I think it's in your handouts. Next, choledochal cyst with fusiform dilation of the extrahepatic biliary tree. So we have your type 1 choledochal cyst. So it's actually the most common type. Okay, and the way I remember this is I remember this table right here. Type 1 is first is F is fusiform. So what do you do with F? You remove the type 1 and you connect the intrahepatics to the jejunum. So that's excision plus Roux-en-Y hepatico-J. For 2 is second is S is saccular. So saccular diverticulum, you have a sac there. That's type 2. You just excise and put a T-tube in there. Type 3 is type 3. When I look at the number 3, I think of a sphincter, right? I think of an ampulla, right? So the type 3 is a choledococele and it's usually resolved by sphincterotomy. Okay? Type 4A, that's extra and intra. Type 4B, that's extra. Type 5, that's intrahepatic duct only. right? So what's the pathognomonic sign? The pathognomonic sign is a long common BP channel, biliary pancreatic channel. So remember, you have your biliary channel, you have your pancreatic channel, both of which drain to the common bile duct going to the duodenum, right? So pancreatic fluid, bile fluid. If it's very long here, what happens is that the pancreatic fluid is going to activate the bile fluid. If it activates the bile fluid, it's going to irritate the common bile duct. If it gets irritated, it's going to get bigger and bigger and bigger. If it's bigger, it becomes a choledococele, which is a sacral outpouching or a fusiform outpouching of your CBD, right? So what's the risk? So if you see choledococele, would you leave it alone? No, because the large size of that choledococele, along with the continuous inflammation and irritation, will predispose the patient to having cholangiocarcinoma. And this is a very high yield question in the board exams. Choledococeles need to be resected because you don't want to risk malignancy later on, specifically your cholangiocarcinoma. Next, for liver abscesses, pyogenic abscess, that's Escherichia coli, treatment is antibiotics for 8 weeks. Okay, so when you aspirate, you see purulent material, then most likely it's pyogenic abscess, but you can do cultures on it. However, parasitic liver abscess, you usually have a case, travel to an endemic area, Mexico, Philippines, poor sanitation, limited access to clean water. You're thinking of amoebic abscess. E. histolytica, or your entamoeba histolytica. If you get a fluid, you're gonna get your characteristic anchovy sauce. What do? You just give metronidazole for 7 to 10 days. Okay. Next, you see an abscess with double wall on CT. You think it's a hydatid cyst. Okay. In patients with sheep and in places with sheep and dogs, and endemic for hydatid cyst, started on albendazole. What's the best time to perform an aspiration? So you see a cyst, it's hydatid. You think it's endemic. It's there's parasites there. When do you do aspiration? Again, just a trick question. Sorry, my camera keeps getting off. Doc, you can cut me off. I think I'm having technical issues with my camera. So, best time to perform an aspiration, you perform aspiration, never. Okay, you don't aspirate. Okay, it's usually your E. granulosus. Okay, why? If you aspirate it, it's gonna become the allergen is gonna spread out. And it's become the patient can become anaphylactic. Okay, a little bit more, just 5 slides more. I know, sorry. 6 slides more. What's the most common liver tumor? This is your hemangioma. If hemangioma with a consumptive coagulopathy, if it's very large enough and it's consuming your blood coagulation factors, it's called your Kasabach-Merritt syndrome. Hemangioma, what do you do? If patient is symptomatic, even if though it reaches very large sizes, we don't need to do anything. Basta provided the patient is symptomatic. What's the second most common liver tumor? That's your focal nodular hyperplasia, which is characterized by a central stellate scar. A scar. Focal nodular hyperplasia, stellate scar. Next, 40-year-old female taking OCPs with root of a liver tumor. What's the most likely etiology? OCPs, think of adenomas. Basta female OCPs, adenomas. So adenomas, are they benign or malignant? They're benign. However, the problem is that, especially in females who are taking OCPs or who are pregnant with excess of estrogen, the adenomas are going to get big, 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 big. Eventually, they're going to lose blood supply. They're going to become necrotic and ischemic, and they're going to rupture into the abdomen. So for adenomas more than 45 cm, you usually excise them. Right? But the first line of treatment, for asked adenoma, taking pills, pregnant, what do? You stop taking pills, or you don't terminate the pregnancy, right? But usually it's associated with pregnancy. So you observe after pregnancy, you try to manage it conservatively as best as you can. Next, history of multiple episodes of pancreatitis with hematemesis. Diagnosis, you have a splenic vein thrombosis. The splenic vein is thrombosed. The stomach is gonna get, the vessels in the stomach are gonna get, are gonna dilate. So we're gonna have varices from it, right? So treatment, we do splenectomy, right? The most common indication for splenectomy overall is still trauma. However, hematologic disorders, carcinomas, among others, are also indications for splenectomy. However, the most common is trauma. What's the most common complication? It's infection. The most feared complication, it's OPSI, overwhelming post-splenectomy infection. Okay? So OPSI is very feared because it can predispose a patient to severe sepsis, which cannot be reversed in order to prevent it, you only need to do vaccination. So vaccination, when? 2 weeks before, if elective, 2 weeks after, if stat or emergent. If elective, you need to prime the body that you're going to lose the spleen. So you need to produce as much antibodies as you can. If stat, you need to wait after 2 weeks because after you remove the spleen, the body is going to be in immunocompromised state. It is not going to be able to process those antigens from the vaccine immediately. So you need to wait until 2 weeks after. So you have 3 organisms, the 3 of which are capsulated because the spleen supposedly takes care of the capsulated organisms. So if the spleen is not there, the 3 of these you need to vaccinate against. S. pneumoniae, H. influenzae type B, and N. meningitidis. Plus, you can do annual influenza vaccination also. Again, S. pneumoniae, H. influenzae, and meningitidis. Next, what's the most common anomaly of the GI tract? You have your Meckel's diverticulum, in which you have your rule of twos, 2% of the population, 2:1 male, 2 feet, 1/2 under 2 years old, 2 types of mucosa, gastric and pancreatic, in 2 inches in length. Now, I just want to emphasize the parameters here are all in not in metric system. So it's 2 feet, not meters, 2 inches, not cm. Because usually they confuse you with that. Feet, not meters, inches, not centimeters. Right? So is Meckel's diverticulum a true or false diverticulum? It's true. What's the most common presentation in children? It's bleeding because you have heterotopic mucosa there. It's supposedly intestine, but if you have mucosa there that are gastric tissue or pancreatic tissue, it's going to produce acid, it's going to produce pancreatic juice, it's going to irritate the mucosa, causing bleeding. Right? In adults, however, they're past that bleeding stage, and eventually what happens is that they're going to hypertrophy, they're going to get, the cells are going to get, the tissues are going to get larger and larger until you obstruct. Okay, children bleeding, adults obstruction. Next, 3-year-old male with bilious vomiting with current jelly stools. This is intussusception. What's the most common cause of intussusception in children? It's lymphoid hyperplasia, okay, usually from upper respiratory tract infection. In adults, usually malignancy, right? Children, hyperplasia. In adults, it's malignancy. I just want you to memorize also intussusceptum versus sapiens. Septum is proximal, sapiens is distal. Sapiens is the recipient. Proximal, distal is gonna go in, right? Okay. Septum, again, septum, sapiens, recipient, sapiens, distal, it's the proximal, right? 25-year-old male presents with right lower quadrant pain. Surgeon makes patient's lie on his left side and extends the patient's right thigh if pain is elicited. This is a positive. So extension of the thigh. This is the psoas sign. This indicates a retrocecal appendix. If you rotate it, obturator, rotate sounds like, this is the obturator sign and indicates a pelvic appendix. Iliopsoas, retrocecal because the psoas muscle is at the back and you try to extend and stretch the muscle. What's the most common cause of appendicitis in adults? They are fecal leaks. For Alvarado score, we have 2 points for RLQ tenderness and leukocytosis, diba? We have the Alvarado score, Mantrels, migration, anorexia, nausea, tenderness, rebound, and leukocytosis. So, last 2 slides more. Patients brought to the OR, no evidence of appendicitis found. Next step, you explore. If wala appendicitis, you explore. If wala pa rin appendicitis, you remove the appendix. Okay? Most common site of perforation is the cecum. Segment most vulnerable to obstruction is the sigmoid colon. And the most mobile part of the large intestine is the sigmoid colon. So we have the 369 rule there. It's in your handout. Just remember, cecum, largest, thinnest, it's prone to perforation. Sigmoid, narrowest, longest, most mobile, is prone to obstruction and also diverticulosis. Here we have a bent inner tube sign in a patient who is elderly with constipation. This is volvulus. But volvulus means it twists upon itself. So usually it's the sigmoid because the sigmoid is very mobile. The initial management is by imaging and endoscopy. You do detorsion. You push the scope there and you try to detort it. However, if not detorted, you can do surgery. If elective, you can do open sigmoid colectomy and anastomosis. If unsuccessful, you just divert. Last 2. Fistula and ano with no opening 2 cm anteriorly was the anatomic course. So if it's anterior, we have the Goodsell's rule here. If it's anterior is actually downward there. It's a straight line. If it's posterior, it curves. We have a dog here to illustrate that. If it's anterior, it's straight. If it's posterior, it's curved. Except if it extends more than 3 cm, the anterior portion is gonna curve to the back, to the posterior midline. What's the most common type? It's the intersphincteric crystalline ano, and the treatment goal is eradication of sepsis with this treatment modalities. Next, we have, sorry, I'm just gonna go fast here. Dear Ian, a newborn patient, squirt sign is Hirschsprung disease, dilated or normal segment. If it's dilated, it's actually normal. The contracted part or the normal part is actually the defective one, because that contracted part is supposedly they should be dilating, but because you have no ganglions there, it's still contracting. So a ganglionic is the normal, dilated is the dilated is the normal, contracted is the abnormal. Diagnostic test, the rectal suction biopsy. You get there, you get sample there, you try to check for ganglion cells. You have the Swenson, Swab, and Duhamel. So main nutrient of small bowel enterocytes, you have glutamine, amino acid A there, A, small, first letter of the alphabet, you think first part, small bowel, glutamine, amino acid. For colonocytes, more distally, you have your fatty acids now, butyrate, your fatty acids. Sorry, I have to squeeze in so much time, and so sorry I extended too much, but I hope you guys have learned a lot. Just a little thing I have to say before I end. I'm sure I'll be meeting you on Pearl's lecture, but at this point, you need to believe in yourself. Guys, at this point, I may be of no significance to you. You may not know me, but I still believe that you guys can do it. So if nobody like me can believe in you, then I guess you can believe in yourselves. So that ends tonight's lecture. Sorry for extending and for going fast in last part. Thank you.